Well, thank you so much for coming, and it's my pleasure to be here to speak to you all there in Mount Sinai in the critical care department. I'm going to talk a little bit about when medicine comes with an expiration date. And by way of background, I'm a professor here at the University of California, San Francisco. I'm a practicing hem-onc doc. You'll find me there every week in clinic at the San Francisco General Hospital, our county hospital, and I attend on service there a few months a year. I'm also primarily a faculty in the Department of Epidemiology, where I teach a number of courses like on publishing and presenting research and designing clinical trials. And I do a lot of research in epidemiology methods and health policy. All right, let's get started. So, we've been interested in this topic for quite some time. This was a paper we wrote a few years ago called Should Evidence Come with an Expiration Date? And this was a paper I wrote with Palmer Green and Adam Sifu, who's my longtime collaborator. And basically the theme of this paper was that there are many medical practices that appear to be beneficial, but only in the context of the surrounding medical care of the time. The example we used, of course, was a daily aspirin, which seemed to work very well in a population that was enriched with smokers, that had a lot of hypertension that was untreated. But then the same preventive aspirin, primary prevention aspirin studies, when done again in the modern age in a population that was more obese, that had less smoking, that had more statin use, those studies were negative. And so our question was, should medicine and medical evidence that guides our practice come with an expiration date? I think that's particularly relevant for critical care medicine, where a number of our best practices are based on randomized trials from a few decades ago, and it's particularly relevant in this modern world. And, as was alluded to earlier, there's a great new example of this. This is beta blockers after myocardial infarction. This is the REDUCE AMI study that came out from the Swedish group. This is a New England Journal of Medicine paper. And many of us grew up in an era where we were trained that after myocardial infarction, one of the most important mainstays of therapy was beta blockade. In fact, it was even endorsed as a quality metric, i.e. that hospitals and doctors that didn't put their patients on a beta blocker after MI, even in the absence of reduced ejection fraction, they could be dinged for that. They could face a penalty. This REDUCE study was run in, there's some CME comment in the chat. This REDUCE AMI study was run in Sweden, Estonia, New Zealand, but principally was enrolling in Sweden. They enrolled patients with acute myocardial infarction and left ventricular ejection fraction over 50%. The difference here is that unlike the earlier studies, we are now in an era of routine revascularization. So the question is, and there's a whole bunch of other medications we use, including more powerful platelet antagonists. So the question is, does beta blockade versus no beta blockade continue to exert a benefit in this modern era? The primary endpoint of this study was death from any cause, or new MI, and the study has now reported results. I'll put one more caveat here. Some of the patients in this study, a small fraction, they were already on beta blockers when they enrolled in the study. The protocol of this study actually asked for those people to stop taking the beta blocker. So not only did they randomize people to not initiate or initiate beta blockade, they also randomized people to stop taking a beta blocker. And they aimed for sort of a moderate dose of beta blockade in this study. The primary endpoint of this study, I think, is stone cold negative. Beta blockers versus no beta blockers, absolutely no difference in the primary endpoint, the hazard ratio 0.96. Some people look at that confidence interval and they say, it goes from 0.79 to 1.16. P-value is totally negative. We'll talk more about that confidence interval. This is death from any cause or new myocardial infarction, this primary endpoint of the study. People fault this study and they say, they didn't include ejection fraction 40 to 50. And I think that is a reasonable criticism of this study. The authors were scared that if they enrolled people with ejection fraction less than 50, they would be randomizing people who are benefiting from beta blockers to not have beta blockade. This was paired with a lower than anticipated event rate. So the event rate was lower than anticipated. What that means is the confidence interval is wider than you'd want. And both of these problems, I think, would have been solved if they had just enrolled down to 40, ejection fraction down to 40. Here's what the editorial in the New England Journal says. This person says, quote, "A critical axiom in evidence-based medicine is the absence of evidence is not evidence of absence. Since the confidence interval for the beta blockers includes a potential 21% lower risk, close to the old risk that was established in older studies, an actual benefit with beta blockers cannot be ruled out." And I call this a silly thing to say, because I hear over and over in medicine that the absence of evidence is not evidence of absence. And that is logically true. In other words, that simply because you fail to find a benefit doesn't mean a benefit doesn't exist beyond the threshold of what you can detect. But the reason I say it's a silly thing to say is that in medicine, most things don't work. I think When you say the absence of evidence is not evidence of absence, the reader may be under the belief that there are all these things out there in the universe of potential medical practices that would save lives if only we could do the right study and document that. The reality is the vast majority of things don't work. They don't improve outcomes in medicine. And I'll give you a few ways of thinking about this. One, probably in the history of humanity over the last 4,000 years, we have attempted 10 to the power of 8, 10 to the power of 9, or 10 to the power of 10 different medical interventions, from trepanating skulls to phlebotomy for George Washington's pneumonia. If you look at all that 10 to the power of 10 interventions we've tried over millennia, the vast majority did not make people better off. They probably made people worse off. Phlebotomy was in vogue for hundreds of years. It turns out that they were right in two conditions, hemochromatosis and polycythemia vera. But all the other people who were phlebotomized, they got it wrong. So most things don't work throughout human history. I think that's one fact. The second fact, even in the era of targeted precision medicine, precision oncology, genomic medicine, the vast majority of candidate compounds that are pursued by pharmaceutical firms that are incentivized to find successful products, the vast majority don't work. We're talking about maybe 1 in 10,000 compounds tested in mice make it all the way forward to humans. We're talking about from phase 1 to clinical approval, maybe 1 in 25 compounds clears that hurdle from phase 1 testing to clinical approval, and that's even with a low clinical approval bar. If you ask what % of compounds entering phase 1 studies actually extend survival of cancer more than 4 months, you're talking about maybe 1 in 100 or 1 in 200 compounds. And that's with all that preclinical science to make sure that it hits the target, that it has really adequate safety, that is animal testing. That's even with all that. So I think we forget that most things in biomedicine, certainly in critical care, most things don't work. And I'm going to show some sobering data there. Reduce AMI is not going to be the final word on this topic. We've got a bunch of other studies coming. And these studies are randomizing people to beta blocker versus no beta blocker, and they're dropping the ejection fraction down to 40. They have sort of different enrollment criteria. You can read that here in the editorial. I think the final word is yet to be determined, but I think this is a very damning indictment of one thing in particular, which is this should never have been a quality metric. These quality metrics that are imposed on doctors place an undue burden on doctors, and very rarely, I can't even think of a single quality metric that has robust level 1 evidence that the institution of the quality metric actually makes people better off. Door to balloon time actually has some caveats. Antibiotics within 4 hours of having pneumonia diagnosis in the emergency room, that backfired. Many of these quality metrics make life very difficult for doctors. They create perverse incentives, and this was a quality metric that simply didn't work. I'll also add, I think quality metrics around cancer screening are misguided as well. In the field of critical care medicine, you all have witnessed a number of high-profile, what we call medical reversals, and this was the topic of the book I wrote with Adam Sifu called Ending Medical Reversal. And by what we mean by reversals are medical practices that were instituted for a period of time, years or decades, that were done widely outside of clinical protocols, outside of randomized studies, outside of registration studies. These were just implemented in the community. And not only were they found not to work, they were found to be no better than a prior or lesser standard of care. These were things that were wrong, not just in retrospect, they were wrong at the time, and we didn't study them often appropriately. There are some really interesting reversals in the field of critical care medicine that are based on single-center randomized controlled trials that failed to be replicated in the multi-center setting. One of which most famously is, of course, the Netherlands study on tight glycemic control in medical ICUs. When I was in training, 2009 to 2012 as a resident, the mantra was tight glycemic control, until in 2009, the NICE sugar study came out. So based on the results from the Netherlands, we thought tight glycemic control had better outcomes for people in the intensive care unit. NICE sugar is a multi-center randomized controlled trial asking the same question, and it failed to find that benefit. Now, you may ask, well, maybe the multi-center study gets it wrong, and the single-center study gets it right. I think that's an incorrect interpretation. We want multi-center studies because we want medical practices and interventions that can be scaled beyond single centers. We want things that don't just work in the Netherlands or don't just work in Manny Rivers Hospital in Detroit. We want things that work in our hospital. And multi-center clinical studies are asking that question. Does it work in your hospital? Does it work in a hospital that's different than the hospital where there is a charismatic and devoted leader who's interested in the success of the product. Early goal-directed therapy, for many of us, it felt like common sense resuscitation, but it was a formal protocol. It initially had a positive result in the study by Manny Rivers from Detroit, and it was contradicted, I think, now in 2 randomized controlled trials that are run in the multi-center setting. I wish I had done this paper. This is one of the few papers I kick myself when I see that it's been published, and I had been thinking about it for years, and I've been saying it in my talks, and I never did it myself. I wish I'd done it, but hats off to these investigators for doing it. It's called Positive Single-Center Randomized Controlled Trials and Subsequent Multi-Center Randomized Trials in Critically Ill Patients, a systematic review, and they did exactly what you'd want to do. They do an empirical analysis of clinical questions that were studied both in the single-center setting and in the multi-center setting, and they ask, what is the concordance? What do they find? Which ones are getting it right? Which ones are getting it wrong? They found 19 single-center randomized controlled trials in critical care medicine published in the creme de la creme of biomedical journals, New England Journal, JAMA, and The Lancet. They followed these studies out and to see how many of them had at least one subsequent multi-center randomized controlled trial. That was 16. In one case, it was confirmed. The results were validated in the multi-center study. In one case, it was profoundly refuted. And in 14 cases, the results were not statistically significant. They call that neutral. I think that is a contradiction to find a significant result that vanishes with further study. These were the topics they studied. You'll see intensive insulin therapy is on there. You'll see early goal-directed therapy is on there. Beta blockers in sepsis is on there. Oxygen targets. Timing of renal replacement therapy is on there. Whether or not people in acute renal failure need high-intensity renal replacement therapy. Non-invasive ventilation in immunosuppressed patients is on there. I mean, this is really an indictment, I think, of what we have been doing. Intensive insulin therapy, of course, statistically significant mortality increase was seen by pursuing that strategy. So it actually was harmful. And only epinephrine during cardiopulmonary resuscitation was validated, I think. All right. So that's a little bit of a prelude, and we can talk more about that. But I think it's important to keep in mind that what are the conditions where you'd want to reassess the medical evidence? You want to reassess medical evidence when the backdrop of medical therapies changes, like with acute myocardial infarction and routine revascularization, when there are many other novel entrants in the space, again, acute MI, and you want to reassess the evidence when the initial evidence was based on, a unique single-center study and a unique study design. So maybe instead of randomized controlled trials, you could look at before and after studies by way of something you all work on. I mean, the practice of routine gown and glove precautions and universal screening for MRSA and VRE has been common in the ICU setting and is still done in my hospital and many other hospitals. But we have 2 multi-center cluster randomized controlled trials, STAR ICU and BUG, both of which are profoundly negative studies. And a lot of that practice is based on before and after studies that come from the prior era. Before and after studies, in my opinion, aren't as good as randomized controlled trials because they also incorporate the Hawthorne effect, where people start to behave better merely because they know they're being studied. I think rapid response teams is another great example where if you look at whether or not rapid response teams move people from having codes on the floor to the ICU setting, the answer is sure, they move those people. But whether or not they actually improve mortality is absolutely uncertain, and merit suggests that they don't improve mortality. They just merely change the room in which you die. And so I think that for health policy interventions, particularly around critical care medicine, we need cluster randomized controlled trials before we implement new measures, or at least concurrent with implementation, and certainly also before they're enacted as policy metrics. Now let's talk about COVID-19 therapeutics, because I figured you all want a little bit of controversy in your lives. I'm going to argue that actually the data for every single COVID-19 therapeutic is expired. I mean, COVID-19 therapeutics have expired because the backdrop has changed so dramatically, and the virus and the way in which the virus acts in the body and the strain of the virus and the harms from the virus are fundamentally different than first quarter of 2020. In first quarter 2020, we had a certain IFR. I'm going to show you what that's happened over time. In first quarter 2020, we had no population level immunity from prior infection. We had no population level immunity against spike protein from vaccination. Now it's 2024. We have huge amounts of population level immunity from prior infection, huge amounts of double immunity from 2 prior infections, and huge amounts of vaccine-induced immunity, and many people with hybrid immunity. And we have a virus that's fundamentally different in sequence than the original virus. And so the data for all of the COVID-19 therapeutics, I think, has expired and really warrants serious reinvestigation. I'll just talk about a couple examples. This is Paxlovid. In 2023 and 2022, we wrote a couple of articles where we call it a regulatory gamble. And the reason we said it was a regulatory gamble was that Paxlovid was initially validated in a randomized controlled trial called EPIC-HR, which tested whether or not it improved outcomes and lowered the risk of hospitalization in adult patients with COVID-19 who hadn't gotten any vaccine doses and hadn't had COVID in the past. Okay, they hadn't had vaccine doses and they hadn't had COVID, and they had high risks. They had risk factors for progression to severe disease. And it was done at a time where the prevailing strains were prior to pre-Omicron strains. And in the pre-Omicron strain era, for somebody who's never been vaccinated and never had COVID-19 and at high risk of bad outcomes, Paxlovid seemed to work. But what we had no idea was whether or not Paxlovid has any benefit in somebody who has been vaccinated or double vaccinated or triple vaccinated, and somebody who's had and recovered from COVID-19, and in the era of Omicron and beyond. We had no data for that. And yet, the current administration granted Pfizer a $5 billion contract even before EPIC-HR results were known. And the current administration pushed very hard, gave another $5 billion, $10 billion in government spending on Paxlovid, and pushed very hard on television. You'll remember Ashish Jha on TV every day saying, got COVID, have Paxlovid. It's good for everyone. Talk to your doctor. This was administered in widespread fashion to low-risk populations in my city of San Francisco. 20-year-old tech workers with no risk factors for progression who work at Google and Facebook were taking Paxlovid routinely. There was never any evidence to support that, and we call that a regulatory gamble. The FDA shouldn't have even authorized it, is what we wrote about. We weren't the only ones. Todd Lee from McGill University and Andrew Morris and others, they wrote, "What is the place in therapy for Paxlovid?" And they outline many of the same concerns I've just detailed to you. This is a figure that comes from the Financial Times. I think it's really illustrative. If anything, if it was updated to the modern, it would be even more sobering. But there's no doubt in my mind that COVID-19 was a serious threat, of course, in 2020. And through the winter of 2020, it was a devastating threat. Thankfully, in 2021, because of the vulnerable groups, older people who had not previously had COVID-19 being vaccinated, we see a dramatic reduction in the infection fatality rate. We can debate whether or not, to what extent boosters played a role here. I think that is debatable, particularly whether or not they were overused in low-risk populations. And certainly the rise of Omicron or strains of the virus that have much more replication in the upper airways rather than lower airways has contributed to a further decline in the IFR. And now, there's no doubt about it, the IFR, I think, currently is much less than seasonal influenza. And COVID-19 is not the threat that it once was, and our policy has to change. And I think most of the policy has changed around this, except for a few pockets of delusion that still persist. COVID-19 is less lethal, and what this means is that randomized controlled trials that occur earlier in the pandemic are not really relevant to clinical practice today, including remdesivir, including recovery and dexamethasone. Many of these things, including convalescent plasma, they're not really relevant to the patients we're taking care of. For many, many years, Pfizer suppressed the results of the EPIC-SR study. They didn't publish this study. This was the randomized controlled trial that was actually done in people who had gotten some vaccination. It was the only randomized controlled trial relevant to the Biden administration's policy decision to put Ashish Jha on television and tell vaccinated people to take this product. Over and over, they pushed that. And this was the only randomized trial relevant. It has finally now been published. It has been published in the New England Journal of Medicine, spin-off journal, Clinical Evidence, and it shows rather sobering results that there is an increase in adverse events related to the product, 12% versus 4%, any adverse events. There's more, grade 3, 4 adverse events. There's more events leading to discontinuation of the product. So, this is something with adverse events, no doubt. The distinction between emergent events and related events is whether or not in the eyes of the investigator they're linked. And the primary endpoint of this study is the time to sustained alleviation of symptoms, and that is absolutely stone cold negative. Paxlovid versus placebo in people who have been vaccinated, who have been vaccinated has no benefit, frankly. Here's a figure that I put together. It shows all the randomized controlled trials of Paxlovid and molnupiravir. And it shows you the dates in which the trials enrolled. Okay, the dates the trials enrolled are shown here by the bars. These are the different studies, EPIC-HR, Panoramic, which is still the biggest and largest study that's still outstanding. The color gray means that it hasn't yet resulted the outcome. Red means it's a negative study. Green means it was a positive study. Over here, I've superimposed when the prevailing variants were. This is based on, and then I've also superimposed COVID-19 hospitalizations. And so I think what you see these products, both molnupiravir and Paxlovid, had positive randomized control trial data in a world of Delta and at a time prior to Omicron variants. This blue line here shows you the percent of people with spike antibodies in their bloodstream over time on the scale on the right. So in other words, as population immunity has gotten better, as the variants have shifted towards Omicron, the color turns from green to red. It's turned to sobering red. And I think I'll bet you money that Panoramic is going to be absolutely negative study. You know a trial is going to be negative when there's multiple protocol amendments to continue to enroll because their event rate is so absolutely floored because of population level immunity. The event rate in the control arm is so low, it's going to be very difficult for Paxlovid to eke out a benefit. And I think when this trial is ultimately published, it's going to be a negative study. And that's going to suggest that Paxlovid, worse than Tamiflu, might be the single greatest waste of government money globally for a respiratory virus because it was predominantly given to people who don't benefit, who are vaccinated and at low risk of bad outcomes from the virus. Okay. Shown another way, you can see I'll skip this figure just for the sake of time. All right, I'll skip the cost too. This cost is horrific. I mean, even assuming the best case scenarios, we're talking about $112,000 to prevent a hospitalization. The dollar per quality was always unaffordable. It was the great waste of government resources. And just a great example of how resources during the pandemic were pushed towards the shareholders of for-profit entities and not towards policies that might have actually made a difference in communities that might have actually stood to benefit from that money. One more thing. Some people want to justify Paxlovid and they cite to me observational study data to support Paxlovid. I think this is a very foolish thing to do because the people who have the ability to get a doctor to prescribe them Paxlovid are different than the people who don't have that ability. So when you do observational studies, not only are you looking at the receipt of the product, you're looking at the kind of person who seeks out the product, the worried well, and the kind of person with the resources to get the product, the rich and entitled people. And so what that means is you see many observational studies that show results that look amazing. This is Paxlovid on the top. This is molnupiravir on the bottom. Look at that. If you don't get treatment, the cumulative incidence of heart hospitalization is horrific. It's not horrific. The absolute values on the scales are very low, but the benefit is massive. Look at how massive that benefit is. Whenever I look at observational studies telling me to make a causal conclusion about a clinical intervention, I always look at them really closely in a couple of ways, and I compare them to randomized trials when possible. So the same study on the top that's used to justify Paxlovid also looked at molnupiravir, and this was the result they found, a big benefit of molnupiravir. The hazard ratio was 0.37. That's pretty low. I don't see that many hazard ratios that good. But at the same time, the Panoramic investigators in the United Kingdom did a randomized controlled trial in a similar population, and their hazard ratio was 1.06. In other words, when you compare the observational study to a contemporary randomized controlled trial that was run with tens of thousands of participants in each arm, the hazard ratio goes from 0.37 to 1.06. I think that shows you how much bias can be baked into observational studies. This is the bias of being healthy enough to get the product. And also, if you deteriorate very quickly, you couldn't have gotten the product. I'm going to come back to that. There's a phenomenon in observational studies, this was a paper we published in JAMA Internal Medicine, where they work too fast. The intervention works too fast, and it can't possibly be true because nothing could work that fast. And here, let me give you some examples. In the initial randomized control trial that reported results in November 8th, 2020, this is the initial randomized control trial of the Pfizer-BioNTech vaccine versus placebo. This was the primary endpoint of the study. This is why we celebrated, why I rushed to get that first dose. This is symptomatic SARS-CoV-2. You have symptoms that require swabbing, and then the swab tells you have COVID-19. In this randomized control trial, you see very clearly that the vaccine is better than placebo. But I want to draw your attention to the first 10 days. In the first 10 days after receipt of the product, not only is there no difference, the curves are superimposable. Why Are the curves superimposable for 10 days and then they start to split? Maybe somebody could put that in the chat. Why don't they split immediately? You can shout it out or put in the chat. This is a test if anyone's still awake. Why don't they? Okay. Well, obviously, what I'm hoping somebody would say is that it takes a while for it to start working. Your vaccine doesn't work immediately. You got to wait for the antibodies to build up, and then you got to, it takes a while for it to start working. So we know it takes probably 7 to 10 days for the vaccine dose to start working because it needs to rev up antibody production. So what am I to think when I read a paper in Nature Medicine that's an observational study comparing people who got 3 doses of vaccine, 1 booster, first booster, to people who got 4 doses? This comes from the Israeli investigators. And this is literally the reason we don't have any randomized controlled trials for a 4 versus 3 that are pursued, that sought clinical endpoints. This is the basis of that recommendation. This is what all the experts on Twitter and social media and the administration are saying why you should get it. This is what I see. I see death from COVID-19, 3 doses versus 4 doses. And what do I see? When do the curves start to split? They start to split, in my opinion, maybe day 12, 13, they start to split. They're already splitting by day 12 or 13. How is it possible that they can split on day 12 when it takes you at least a week to rev up antibodies? And then it takes you a while to avoid getting sick. And then it takes you a while to avoid having progression and respiratory failure and avoid getting on the vent and then avoid dying. It splits too fast. It splits way too fast. It's not possible that it could work this fast. And that tells you that the people who are getting 4 doses are fundamentally different than those who get 3. In fact, they're more likely to be higher educated. They're more likely to have more wealth. They're more likely to take other precautions in their lives. This smells like confounded data. And yet it's something that's missed by many people. This is an example of Eric Topol. He says, look at this massive reduction in death and hospitalization from Paxlovid, but look at the curves. They split on day 0. Paxlovid starts to work literally before you even took the first dose. You didn't even haven't filled the prescription yet, and Paxlovid's already reduced the risk of mortality on day 0. How is that possible? That's only possible because of guarantee time, meaning that there's a certain amount of time guaranteed to somebody who took Paxlovid. They couldn't have gotten hospitalized before they filled the prescription. That's called immortal or guarantee time. And the other reason is it speaks to confounding, that people who pursue prescriptions are people who are more worried and more able than people who don't pursue those prescriptions. When you look at these Paxlovid observational studies, you see this. This is impossible. Paxlovid cannot work before you take it. That's impossible. And so that's why I don't trust these observational studies. Okay, that's why we need randomized trials. All right, then the next thing I'll argue, if you're all still interested, I'll argue that, what year is it now? 2024? This fall, we're going to get another booster, and then the hospital's going to have some booster program. I've had 3 doses of the vaccine, and I've had COVID, I think, twice. Once I've documented, and once I'm pretty confident I've had it. Okay. Is it possible? Is it credible that I have a benefit to myself or a benefit to anybody else by getting the annual booster in the fall? And the answer is there's absolutely no credible data for that claim. There is a risk to me to get it. There's a risk of myocarditis. I'm still on the tail, not that old yet. I'm still on the tail edge of the higher risk of myocarditis. There's no proven benefit to my patients because there's no sustained reduction in transmission that's ever been demonstrated. And there's no proven benefit to me for getting it. So why is the FDA allowing this to be recommended year after year? This is Peter Marks. He's the FDA scientist who's making this call. And I would say, my position is, the US FDA has an obligation to demand that the company that's made $100 billion from these products run a simple randomized controlled trial for boosters that's powered and designed to assess clinical endpoints. They got 100 billion reasons why they can do it. So why don't they do it if they want to keep selling me the product? That's not even my idea. That's an idea that was proposed by, oh my God, is this Peter Marks, the same person who's approving it? He wrote an article in JAMA in 2022. What did he say in this article? He says, quote, although experience with mRNA vaccine platforms has enabled authorization of updated versions of vaccines without large clinical trials, when more significant modifications are made to a vaccine, the clinical effects are often unexpected. Biological properties that may plausibly have benefits often have unanticipated consequences. Therefore, unless correlates of protection that are strongly associated with duration of protection against COVID-19 can be identified, and let's be clear, none have ever been identified, it is likely that rather than relying on immunobridging, which means antibody studies, to infer vaccine effectiveness, Peter Marks writes, large randomized clinical trials similar to the initial trials of the currently authorized or licensed vaccines, the 40,000 person studies, will be required to ascertain the effectiveness of these new vaccines. This was Peter Marks' idea before he fell under, I think, tremendous pressure to approve this year-over-year product. It was his idea that they need to do bigger randomized studies powered for clinical outcomes. Other nations don't do what we do. Other nations are not going around asking 7-month-olds to get an annual COVID-19 booster. They don't recommend it. Their CDC does not recommend it. This is the NHS. It's recommended for predominantly older people over 65 and up. Sweden, recommended older people or high-risk groups. Italy, again, older people, high-risk groups. France, older people, high-risk groups. Germany, older people, high-risk groups. Portugal, blah, 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 New Zealand, blah, blah, blah. No country in the European CDC recommends COVID-19 immunization for healthy children currently in the European CDC, and yet in the United States, it's recommended for everyone 6 months and older and every single year. It's completely outside of any global norm and not justified by any evidence, and done at a time when the actual harms of the virus are plummeting and population level immunity is soaring. It really defies logic, in my opinion. All right, I'll skip that. Another point, Paul Offit himself, he doesn't support the annual COVID-19 booster policy. Paul Offit, a man who's invented the vaccine himself. So I think surely he should be above the criticism that he could possibly be anti-vaccine because he's a vaccine developer. He says that the recommendation makes less sense even now. And then he says, wouldn't it make sense to get an additional dose to prevent your chance of having long COVID, which is characterized by fatigue, headache, brain fog, and muscle aches? And then he asks, quote, are there data to support the additional doses beyond what most people have actually gotten? Because most people have already gotten a few doses plus a natural infection, which is defined as hybrid immunity. Is there evidence that an extra dose makes a difference? And the answer is absolutely not. There's no evidence that the annual dose is going to lower your risk of long COVID. And Offit, who is 72, who's already had COVID-19 once, he didn't get the bivalent booster, and he's not going to get the new one. Okay. And then finally, the FDA officials, Marion Gruber and Phil Krause, they resigned. These were two people who worked in government for 20 years. They resigned under pressure to approve a COVID booster for all ages, including young people, even though that did not have strong evidence. They didn't resign in the prior administration. They resigned in this administration in the fall of 2021. They wrote an op-ed saying, we don't need universal booster shots. Okay. American people don't want it. Of course, nobody's taking the shot. And of course, finally, the COVID-19 fall booster last year actually didn't target COVID-19 at all. It was for XBB 1.5. And actually, XBB 1.5, if you looked at the CDC's sequencing data from the fall of last year, I highlight where XBB 1.5, by the time they even debuted the vaccine, it was already diminishing and it was not a contributor. The majority of COVID-19 in the fall of last year was not in the booster at all. They missed entirely. And then the last point I'll make is that it was a net harm to some subgroups. There are definitely people who have suffered net harm from vaccines and vaccine mandates, particularly booster mandates, and that's in contrast with what Rochelle Walensky was saying as part of Transparent Public Health. Rochelle Walensky says, quote, April 27th, the U.S. CDC has not seen the link between heart inflammation and COVID-19 vaccines. They say, we looked at 100 million cases. We didn't find any myocarditis. That has to be incorrect because, of course, the Israelis had already reported 2 months earlier that the risk was 1 in 3,500 for young men, and that's a risk that's sort of been zeroed in on by multiple population studies. We did a very simple paper led by Kevin Bardosh where we looked at universities that mandated a third dose for young men, and we calculated the upper bound absolute risk reduction in hospitalization from going from 2 to 3 doses versus the actual risk of myocarditis from going from 2 to 3 doses, which has now been published by Katie Scharf in the Kaiser Permanente Experience. And we compared the two. And so here we're going to show you the red bar that shows the risk of myocarditis. And this is myocarditis that prompts medical care. And then the smaller bars are going to show you the risk of hospitalization, maximum risk of hospitalization prevented with booster. And what you see is the serious adverse events are just so much beyond what could possibly be averted. Myocarditis exceeds any potential benefit from boosting strategies. So it is very likely, I believe, that we did do net harm by mandating the third dose in young men, particularly men in the target demographic of 16 to 24, the highest absolute risk. One thing you may hear is that, well, myocarditis is worse from COVID-19 than the vaccine. Number of groups, including the Oxford group, have published that. I think that's dishonest in two fundamental ways. One, when you look at myocarditis, we're not talking about myocarditis in an 80-year-old grandmother. I'm not worried about that. I don't think she has a risk of myocarditis from getting booster after booster, and she's welcome to continue to get boosters. For an 80-year-old in a nursing home, continue boosting, have at it. I'm not even going to be a stickler for strong evidence there, if it's her choice. I'm talking about myocarditis. It's a risk in young men. And in this analysis done by Ben Knudsen, a medical student, what we show is that there are many, many studies. Each bar here comes from a study. Many, many studies on myocarditis after vaccination. Some of them, on the rightmost, use zero stratifiers. By that I mean they look to see of 100,000 people get the vaccine, how many got myocarditis? And you can see it's pretty low. Look how low that number is, 1 to 2. But some of them use one stratifier. They say, let's just look at people in a certain age group. Let's just look at men instead of women. Let's just look at Pfizer instead of Moderna. And they start to get a little bit higher. Some of them look at 2 stratifiers. They just look at men in Moderna compared to everyone else, or men in dose 2. They start to get a little bit higher. Some look at 3 stratifiers. They look at men, dose 2, and they look at certain age groups. Well, they start to get, now they're getting higher. And then finally, when you look at 4 stratifiers, just men, just Pfizer, just Moderna, and just the target demographics that are at risk, you find massively increased risks. So of course, it's very possible that the risk of bad COVID outcomes is worse across the whole population. 80-year-olds have more benefit from vaccination than they do have harm, I have no doubt. But that's different than a 20-year-old man. And medicine has to have policies that separate 20-year-old men from 80-year-old women. If we cannot tell them apart, we're not doing a good enough job. So these studies, I think, are dishonest because they don't break apart the risk in the target groups. Similarly, when we talk about myocarditis after COVID, all of the studies that are being talked about, the denominator for COVID is not everyone who had COVID. It's not everyone who had COVID. No. It's not a seroprevalence denominator. It's not even everyone who tested for COVID and tested positive. Oh, no. They don't have home tests. It's only the people whose COVID diagnosis was documented in the electronic health record. That's not only not everyone with COVID, that's a tiny fraction of people who've had COVID, and they're probably the sickest people. So if you look at what's the risk of death from food poisoning from eating McDonald's, if you looked at everyone who ate at McDonald's, the risk of death from food poisoning is very low. But if you just looked at the people who were hospitalized in the intensive care unit with food poisoning after eating at McDonald's, well, then the risk of death might be much higher. Because you're not looking at the real denominator. And it just kills me that I can't believe people keep citing this statistic. The denominator is not the real denominator. So why would you say that? They would be like concluding that McDonald's is killing all these people because each year 4 people are hospitalized with food poisoning in the ICU and 2 of them die. So it is a 50% death rate from food poisoning. And it's worse than, whatever. But of course it's not. It's mostly, of course McDonald's will kill you, but, not for the food poisoning. It's just that it's just terrible food. Okay, no, all right, anyway. Medicine without evidence. The last thing I'm going to say on this talk, and then, unless you all have questions or you want to keep going, you can't tell, you're all quiet. We're moving to a world where we talk about expiration dates, we talk about reassessing the evidence, but we're moving to a world where we're just so far past that we're just implementing medicine without evidence at all, and no one seems to have any interest in generating evidence, and I think at some point, we have to ask ourselves, are we any better than the people who bloodlet George Washington and killed him? Are we any better if we don't run any studies, we just set policy, we just make things up? And here's the policy at my university. I got this email. After 4 years of having to wear a mask in clinic, I was told in May 1st, I don't have to do that anymore. And so the patients and I, we celebrated, we threw our masks into the air. And then we picked them up because, of course, they're an environmental hazard. So we had to throw them away. Okay, we picked our masks up. And then I got this email from the bosses. And the bosses say, congratulations, you don't have to wear masks anymore. But face masks are only required in the following time periods. During the annual respiratory viral season from November 1st to April 30th. And I said, November 1st to April 30th. That's April, May, June, July. That's 6 months a year. What the heck are we talking about? We have a mask mandate at UCSF for the future, forever, 6 months a year. So 6 months without mask, 6 months with mask. What evidence is there to justify this, I ask myself. There are 3 endpoints I think that the administrators may care about. One is nosocomial infections. We don't want to spread virus to our patients. That's terrible. One is we may want to decrease cumulative infections of people who walk in. Our policy is not just on the floor, not just seeing patients. Our policy is in the gift shop. Our policy is in the hallways. Our policy is in the cafeteria. Our policy is in the cafeteria line. 6 months a year, you got to wear a mask while you're waiting in line for your food. Okay? The third reason maybe is that people in the community want it. As far as I can tell, they have no robust evidence that it slows nosocomial spread. 2, they have no good evidence that it reduces cumulative infections by people who pass through the hospital. And 3, they actually have no idea what our patients want because we've never surveyed our patients. And finally, I ask, why does the policy work on Thanksgiving but not on Halloween? The policy they've implemented is something that only works in some holidays. It doesn't. November 1st it works, and October 30th it doesn't. That to me is ridiculous. If you want to test it in a way you can find out if it works and when it works. They're just making up rules. And the last thing I'd say is these rules, I think, have nothing to do with science. They're fundamentally political, and I can prove it to you. Sarah Miller and I, we looked at all of the mask loosening in 2023 in the first quarter. We looked at all the hospitals and when they dropped mask mandates, and we did regression analysis, and we asked, do mask mandates fall in hospitals when the cases drop, when the hospitalizations drop, or is there a third factor that explains why masks fall in some places and not others, and are sooner and rather than later? And the answer is, on COVID-19 cases, the odds ratio is 1. The cases in your community have nothing to do with whether or not you extended the mask requirement. Hospitalizations, it's 1.06 and it has nothing to do with your hospitalizations, dropping the mask mandate in your hospital. But for every 10% increase in vote for the Republican candidate for president, you're much more likely to drop your mask mandate sooner. And that to me is the problem, that we have abdicated this policy decision, this medical decision, to simple partisan politics. And the reason, of course, San Francisco is going to continue to mask is that we don't have a 10% people voting for the Republican. We have a 0%. This is a Democratic city. So we're going to mask until our earlobes fall off. All right. I'm going to pause there. I have 2 things I could talk about. I could talk about Entresto and why this is a very bad randomized trial, Paradigm HF, and why Entresto probably doesn't work, which I think is very interesting. I think Entresto is the greatest scam ever perpetrated on the heart failure community. Or I could talk about the science paper on Bangladesh, cluster randomized trial masking, a randomized control trial, and why actually, even though it looks like it's working, it actually is a really flawed randomized study that has this one problem of concealment bias that's such a devastating problem that in some ways it's actually not a randomized study. It looks like a randomized study, but it's not really randomized. So those are the 2 bonus things you can pick from. But I'm going to stop now and take questions and see we can talk about either of those 2 studies or something else entirely. So thank you for having me.
Hey, this is Dr. Gopal, Critical Care from Mount Sinai Morningside. Breath of fresh air, wonderful talk. Classic activated protein C.
Oh, yes.
Weekly.
Zygris.
Yeah.
Yeah.
Even now, balanced versus non-balanced solutions. We live in an algorithmic cookbook medicine sort of situation, where fellows and residents are taught and institutionalized protocols when COVID came about. Plaquenil was intro based on limited Wuhan studies. You become a pariah if you go against all this. After all of that, what's your message?
That's a good question. I mean, I remember Zygris. I remember giving it and then not giving it. It all happened when I was a trainee. What's my message? My message is that, I think that you're absolutely right. People don't use their brain and follow guidelines. And so I get angry, actually, when the fellow tells me, why do you want to give this patient this chemo? Oh, NCCN says. Oh, NCCN says? No, that's not the answer. The answer is, why do they say, and do you agree? So do that. So I think we should all do that extra level of work, which is, why do the guidelines say to do it? And do we agree with the guidelines? And I think that's not easy, and you can't do it every day for every question, but once a week you pick one question and do it, and over a year, you're going to be really good at sort of having a detector that says, okay, maybe this is an exuberant recommendation. So I think that's one thing we can do. The next thing I think we can do is, this is something that John Mandrola and Adam Sifu and we talk about. We call it the case for being a medical conservative. And we don't talk about, it's not political conservatism. We just mean that when something new comes along in medicine, we have to be skeptical of it. This last month, I see there's the first ever randomized control trial that shows Impella improves outcomes. And we've been doing Impella for 10 years. And I think it's easy to say, well, we've been doing Impella, and now finally we've been proven correct that Impella saves people's lives. But that randomized trial has problems. One is the p-value is 0.04, and then the cutoff for significance is 0.048 because they took an interim look. Okay, so it's barely significant. That's one. 2, They exclude people with out-of-hospital cardiac arrest, which is the majority of the reason why we're putting the impella in the first place. They're not even including those people. 3, they enroll over a very long period of time. 4, in the control arm, if you have hemodynamic collapse, they put you on ECMO, and you're getting ECMO in double digits. Much more people getting ECMO than the control arm. Well, that ECMO that they're getting might not be a salvage. It might even be harmful. And so when I start to see like so much money, billions of dollars, and so many people being committed to a practice where the best available randomized study is P of 0.04 after many, many years, and the pretest probability of IABP and all these other and ECMO was negative in a prior randomized study, the pretest probability is low. I think the totality of the evidence has to be skepticism, and the best answer is I think we should just do a bigger randomized study and get NIH to do it. Okay, so I mean, so my answer, yes, sorry.
I gotta tell you, there's a ton of questions people
All right.
Was not maximal and so on, so people want to know now, can you in the next 8 minutes talk about one, the fatal flaw in the masking RCT and the fatal flaw in the ARNI trial?
All right, I'll do the masking RCT first. It's a quicker one. Oh wait, no, I have the right wrong slide deck. Okay, sorry, wrong slide deck. Okay, let's do the masking RCT. It's a fun one because I didn't see it initially, so it really bugs me if I don't see it right away. Took me a while. Okay, so this is a cluster randomized control trial in Bangladesh. It appeared in the journal Science, and what they did was I think they took something like 300 villages and they matched them at baseline. So they say, this village has a population of 40,000 people, this other village 40,000 people, rural Bangladesh. This is a match. And this village is 10,000, this village is 10,000, this is a match. They create 300 pairs of villages. And so they know the villages in one arm and the villages in the other arm are roughly the same sample size. And then they randomize each of the two pairs. So they say one arm is going to get the mask and one arm is not going to get the mask. It's done in Bangladesh. It's done in 2020. The baseline prevalence of COVID-19 is essentially 0. It's rural Bangladesh. Nobody had COVID at baseline. They go to the village and they randomize you to an intervention where they pass out free masks and tell you to wear masks. And in the control arm, they don't do that. They just go there and tell you, hey, we're doing a study. You want to participate. The primary endpoint of the study is symptomatic SARS-CoV-2. There's 4 endpoints. Symptomatic SARS-CoV-2 is, of all the people who signed up for this study, if any of you feel like you got a tickle in your throat, a cough, runny nose, you call us up, we'll mail you a little kit, you prick your finger, put a drop, we'll look for antibodies to COVID-19. So this is antibody-confirmed symptomatic SARS-CoV-2. That's the primary endpoint of the study. All right, there's some other endpoints, but the primary endpoint of the study, here's what they found. The comparison villages, 0.75% had COVID-19 by symptomatic seroprevalence. The cloth mask didn't do crap. Cloth mask, we know, is a useless mask. It's a shame we recommended it so hard. The surgical mask was a winner. 11% p-value, 0.043. It's below 0.05. They popped the champagne. They're really celebrating, okay? Surgical masks is the winner. Cloth mask failed. All right, I'll skip that part. Here's one thing that caught people's eye. The villages were matched, and it's a cluster randomized study, and if you looked at the people who consented to participate, it was 178,000 in the masking arm and 163,000 in the no masking arm, a difference of roughly 10%. Another way to put it is, for every 10 people in the control villages, there's an 11th person in the treatment villages. But that's really interesting because that's an imbalance, and it is a randomized study, and we really did try to match that, the baseline sample size. If you look at all the other endpoints collected, the people with symptoms, that's about 13,000 similar. The people with blood samples collected, that's similar. The people who are tested, similar. Everything else is similar, except this. And in fact, some researchers very cleverly here, they create a sort of a distribution. The distribution is, if we sample from the null distribution many, many times, what do we see in terms of symptomatic seropositive? So this is sort of like really sort of another way to look at the p-value. The p-value for the primary endpoint of the study is over here. Like it's something less likely to occur under the null assumption. Like it's, p of 0.1, you can quibble about the p-value, but the p-value is over here. It's like, it looks significant-ish. It looks like it's unlikely that you would have seen that outcome under the null distribution. It only happens sort of some percent of the time. The rate of symptoms is very significant. Like the people in the mask arm, they're much less likely to report symptoms. They're slightly more likely to have symptomatic zero COVID. But look at the consenting population p-value. The p-value for the difference in the consenting population has got so many zeros in it, it's off the chart significant. In fact, the most significant thing about the study, the biggest statistical difference, is the number of people who consent in one arm versus the other. And that's the fatal flaw. Why did that happen? Why in one arm of this study, the arm that gets the free mask, you're getting so many more people consenting than in the other arm? You're getting an 11th person for every 10 person. You're doing this for 170,000 people. And the answer is it didn't have concealment. Now, you may remember, in randomized studies, there's blinding. Blinding means the patient doesn't know they got it, and the doctor doesn't know what they got, and the statistician doesn't know what they got. Blinding is about you don't know what you're getting when you're in the study. Concealment means at the moment you're randomized, you don't know which arm you're being randomized into. And we don't have concealment problems anymore because now we use a digital phone number to call for randomization in clinic. And you call the number and it says the patient's been randomized to whatever, they tell you, right, on the phone. But back in the day, we used to get these envelopes. And you remember doctors would get envelopes for randomization. And some doctors were obviously want to do the right thing for their patient. You get a young woman with breast cancer. I'm not taking a random envelope. I'm going to hold that envelope to the light. And if the envelope says control, I might get the next envelope and get treatment because I want to do everything for the 40-year-old woman with breast cancer. That's a concealment bias that I subverted randomization when I was doing the randomization. And they had it in this study, and here's why. In the control villages, they pull up in a Toyota Yaris and a clipboard, and they consent people to the study. In the masked villages, they pull up in a truck with boxes in the back, and they consent people to the study. And people know in the masked villages, it looks like these American investigators, they got a lot of freebies in that back. And if I consent, maybe they're going to give me some free stuff. And in fact, that's true. And in the control arm, they know they're probably not going to get something free. And so there's an 11th person who agrees to participate because they think they're getting something for free, and there's not that 11th person in the control arm. And that 11th person, if they have a tickle in their throat, if they feel a cough, they have to be equally likely to prick their finger and put the blood on the card and send that card in for this to be a real randomized study. But I would contend they're not equally likely because the kind of person that only enrolls in your study because they're getting a freebie is not the kind of person that wants to prick their finger and send you the blood. They don't care about your study. They just wanted that freebie. And that is, I think, the reason why all the results are the way they are. They have an imbalance in people who are not being ascertained for the endpoint, and the entire study is probably not a randomized study. In fact, it is not a randomized study. There's an imbalance in the population, and it's not at random. It is an imbalance based on knowing some characteristic of the study, which is whether or not you get something for free. All right, Entresto, you're going to go online to my YouTube channel. I got a couple of videos on Entresto because I burnt all my time. I'll walk you through that. But yeah, there's issues with the drug dosing, the run-in period, the double drug run-in period, and there's a little tidbit in the supplement that proves that why the drug dosing is very inadequate. In the supplement, they prove that you could have pushed that dose way higher, and it's buried, and we found it.